Hello, and welcome to Health and Fitness Redefined. I'm your host, Anthony Amen. Joining me today is to take a dive into health and fitness, where we're going to overcome adversity to pick fact versus fiction and see health and fitness in a whole new light. Today we have a nice, fun guest right up from the PM&R world. So, my brother, if you're listening to this, yes, we got another PM&R doctor on. So, very interested to have this conversation with him, and specifically to gear it towards lower back pain, spinal pain, something we've talked about quite numerous times on this show, but I do like getting different opinions because it's important to understand how to help specifically low back pain, because it is the number one complaint any doctor or any personal trainer will tell you that a client has. So without further ado, let's welcome to the show, like Sandra Jim. It's a pleasure to have you on today.
Thanks for having me on, Anthony.
So the first question is, why did you decide to get into pain management? What kind of got you started that way?
I started off as a physical medicine and rehabilitation doctor because I wanted to focus on not just purely medication for helping patients get better. And it seemed a natural connection to have, physical therapy and, a lot of other kind of modalities to treat patients, not just pain medications. But ironically, after I finished my training, I ended up being primarily a pill prescriber. I was a pain medicine doctor at a conventional pain clinic. And in California, like many parts of the country, you have to go monthly for your opioid refills by law. And so I saw the same patients month after month on more or less the same medications, prescribing thousands of morphine equivalents, which is like a measure of opioids per day. And I found the work very stressful and kind of depressing because I wanted to become a doctor to help people reverse and heal their conditions. And here I was kind of palliating their pain, but which is a great thing, but with something that is arguably far more dangerous than back pain or joint pain itself.
Yeah, and that kind of leads to the whole epidemic we have going on now as far as fentanyl and heroin. And the opioid epidemic was the precursor to all of this. You saw tons of information coming out from the prescribing of opioids and how they were uncontrolled and hitting the streets. And then when they were pulled off the streets, people turned to other more unconventional drugs. So it's a sad reality that it came from. I think this is an important description. A lot of people who ended up ODing on these drugs weren't like your typical drug addicts. They weren't people you would expect that would be addicted to these things. It was just they had a low back pain. They went in to go get checked. They got prescribed pain medicine, sometimes way too much, and then they just became addicted to it. So it kind of led down that rabbit hole. And what you were talking about, where it's pushing pills, and ultimately it's been a nightmare that we're still dealing with now. But I get it. I get the reason you wanted to leave and kind of do something else besides that, because it's sad reality.
I hear you. And it's not a simple solution. I mean, if you say, don't prescribe these pain medications that the patients have had already, then their pain increases. They're more sensitive to pain, maybe more than ever. And if you pull medication, whether somebody is dependent on it for physical pain reasons or for, addiction reasons, they're not just going to say, okay, I'm going to take ibuprofen. They're going to get it from other sources, whether that's another doctor or the, so-called black market type forces. So as kind of a professional in the middle, you're trying to help people, you're trying to reduce their pain, and the mechanism that you've been taught. And, these policies are largely from, predate my entering medicine. Opioids were not always a part of the chronic pain management for non-cancer pain. It was really a push by the federal government, along with some of these, big pharma companies that kind of led doctors that changed the culture for them to start prescribing these medications. So by the time I started my pain medicine job, that whole debate was at a fever pitch because it was obvious that there was this tremendous opioid epidemic, and it was becoming one of the leading causes of kind of death in the country. And then it's kind of different as a clinician who's well-intentioned and not, one of these corrupt people, pill mill doctors. You're just trying to help people. the people are coming in expecting a particular service and outcome. And I think done responsibly, there are still risks. You're just risk mitigating, but you only have so much time to spend with the patient. So it becomes an issue of how do you know if somebody really is addicted or not? Sometimes there's clear red flags, but most of the time in communication, there's kind of this gray zone. And so kind of in terms of the cognitive kind of load of like, is this person saying my pain is high? Are they really suffering a lot of pain? It just becomes a very confusing affair. So I was kind of happy to transition into an aspect of pain management and back pain care that was not centered around painkillers and opioids.
Yeah, and kind of to add to your point that you don't really know, I want people to think of it from both sides of the coin, right? It's important to say, like you said, a lot of the physicians didn't overprescribe opioids because they wanted the money. They thought they were actually helping people because it was a huge push, and you're absolutely right. It was in good intentions. And you walk in to see a patient and you get what, 5-10 minutes at best to get a good understanding of where the pain's coming from, how much pain they're in. You're not spending all day with these people. You're not spending hours with them to understand if they really are in pain, what they're doing. Like, you get a quick, here are the notes, go. And then you have to make a decision on the fly and then move on from it because your schedules are so overpacked because they're trying to squeeze in as many people as possible for you to see in one shift. You get burned out, and it's natural human tendency. It's impossible for you to know, is my point. Like, the little time you get with somebody, it makes it impossible to figure out if they are actually are not in pain. And the flip side of that is that even telling people, and I experienced this myself too, what's your pain rating of 1 to 10? People go all the time, my pain's like a 10. Not understanding that, like, if your pain's actually a 10, you shouldn't be able to say my pain's a 10 because you're in that much pain. So there's that, we're just so afraid of hurting and not feeling normal that our pain tolerances have dropped. A tiny little prick. I'm a 10 out of 10 pain. Help. Give me something. And it's like, well, no, that's not. So I don't have anything to add to that, but it's kind of my point. It's hard to judge.
Well, I do. I mean, I think that's a central point is during the federal government's push to spread opioids, they said that pain was a vital sign. And then pain is vital, but it's not a vital sign. And in kind of technical terms, pain isn't even a sign in the strict medical sense. So a sign, like when you think about a vital sign, that's not something someone tells you. You don't tell me what your blood pressure and your heart rate and your pulse oximeter are. I measure those objectively. You can't really fake it. You could change your physiologic state, but the distinction is a sign is objective and it doesn't require someone to tell you what it is. So if you're making the mechanism for someone to get more or less or a stronger type of pain medication based on what is a symptom, then you're actually kind of opening Pandora's box, because whether the person has legitimate pain or is simply wanting, more opioids for kind of other reasons, I think that's what you're kind of comments touched upon.
Yeah, exactly. So I guess the next question and the next natural push to this is, what are the procedures that you think should be done, implemented, so it's not straight out prescribing opioids? So let's say somebody comes here and says, listen, I have lower back pain. What are the next logical steps that someone should take?
Oh, that's a great question. I would say the first step is to understand the cause and the source of the back pain. So often in medicine, such a pain is treated simply as a symptom. So it just means, oh, well, you're hurting, here's a painkiller to mute that symptom. But then the reason you have a pain, it has a cause. And then so the first aspect is to use a combination of clinical diagnosis. I interview you about your symptoms. When did it start? Where does it hurt? And I get these details, and that helps me start to form an idea about what the injury mechanism is. Then I'll do a physical examination. And and then I'll test out my theory. If it's this mechanism, maybe this bend would hurt it, or this bend will relieve it. And starting with that, then we can move on to objective testing, things like spinal imaging, X-rays and MRIs. And usually most back pain, it doesn't need an injection or a surgery. It needs quality rehabilitation based upon the injury mechanism to recover.
Yeah, so let's talk about that. Let's give a specific example. And I think what comes to my mind first is most people will end up pulling, like herniating a disc. That's probably the most common cause for low back pain. I can't tell you how many clients, they're like, oh, I blew my back out. How did I do? Well, I twisted this way. So you're turning in the transverse plane and you're grabbing something from the bottom and then you're twisting back up quickly. That, you blow a disc, your lower back hurts. So if someone has, let's say, herniation in their lower back and it's causing radiating pain, so we know that there's nerves involved, where are we going from here?
The first step is to figure out the level of the pain. So for example, an MRI, in that case, if we're focusing on disc injury, which is the most common type of significant back injury, you're usually dealing with some type of disc bulge. And so on the clinical side, the first thing we're trying to figure out are what was the cause? And then I think you gave a very specific biomechanical description, like twisting with a side bend and a load. And that starts to inform the hypothesis of how this person blew out the disc. And then the next step would be to figure out what makes that pain worse. Because a disc injury that has sciatica, which that's kind of like the typical pain presentation, there's actually a lot of different subtypes of that injury. And so some people, they get pain in their big toe, or other people get pain at the bottom of their foot. So then a clue like that might suggest, oh, a different nerve root is involved. Some people, when they round their spine, their pain gets a lot worse. Other people with sciatic symptoms, when they round their spine and sit slouchy, their pain gets better. And so there's all these further physical ways you can subcategorize these injuries. And so with that, without even quite yet knowing the exact disc level, I can say, well, these things hurt you, these things you tolerate or make you feel better. And from that information, you can begin to design a coaching program based on posture, movement, and exercise that is tailored to that person's unique sciatica presentation.
So we could start with posture, just as a general understanding for most people, because our posture here in the States is horrible. So many people have poor posture, sitting, especially now that we're sitting at desks, computers more, and we're on our phones. I see a lot in the gym is the pressure on the lower back because of poor posture, not sitting upright. So what are some techniques you can give to help with, what are some posture techniques basically that somebody can do to help mitigate the pain from sciatica or prevent it?
Well, the first tip is to avoid postures and movements that worsen the pain. That might sound like a kind of like a snarky comment, but in reality, when I see patients, they don't know that. Many of them say, oh, this exercise hurts, I'm supposed to stop it, because they don't realize that pain is a signal of tissue damage. So I would say that's step one. Simply don't do any activity, even if it's walking for a bit too long, that hurts you. The next step, which would be based on what you learned from your assessment, would be to tune the posture. The correct posture is usually close to something called neutral. That's the position in your spine that the discs, the ligaments, the muscles, they're kind of in that sweet spot where they're not stretched out, they're not twisted, they're not loaded in any which way. And usually the correct posture is somewhere in that area. And the quick way I have for teaching people that is, do you play any sports by chance?
Yeah, quite a few.
Can you give me some sports you play?
Basketball, volleyball.
Okay. So yeah, we've worked with some volleyball players. So in most sports, there's something that is akin to like a ready position. It's this position where you're standing and you're waiting for something to happen. but you're not quite engaged. Like the next action isn't to you, it's to your teammate. But maybe it's before you're going to spike a ball, you're watching
So you're
your
on your
teammate.
toes, you're sitting down into a semi-squat, and your back
Yeah, or
shoulder
but
straight.
like a taller version of that. Like maybe you're on a semi squat, maybe like a taller version where you're standing there casually. Because what people tend to do is, is it the ready position? It's because they're kind of not tense. They're not really stretched one way or the other. They're not puffing their chests out like they might do in their regular life. And then so I would say that ready position, it could even be in an occupation. I saw a butcher and then he was standing, chest poking out, shoulders pulled back, hips extended. And I said, how do you stand in front of the butcher block? And then he says, oh, I just stand like this. Everything relaxed. There was this ease to his movement. So I would say you have to, the second step is finding the sweet spot in terms of posture. And that sweet spot becomes a foundation from which you build other movement. So then a lot of the movements, you're trying to keep that near neutral spine and then move around, like whether you're doing a squat or a pull, trying to keep that motion. And I would say the third thing is your body needs variety. No matter how sweet I shape my spine, if I'm just sitting there all day or I'm at Buckingham Palace Garden, I'm standing there all day, you're going to ruin your joint health, your cardiovascular health. We need variety as well. And that's often the element that people don't talk about. We don't need to be walking all the time, and nor do we want to be sitting all the time or standing all the time. It's really a mix of those things. And so even if you have probably many gym goers who they sit at their, coding job all day, 8 hours, 12 hours, and they come to the gym, they're still not going to be that healthy because there's just too much of one thing at a single time. So I would say those are kind of 3 ideas to get you started.
No, I love that. And kind of speaking of fitness and variety, if you guys are interested in figuring out your health, your fitness, you're going to want to check out F Squared Consulting. It is a brand new company Keith and I have officially launched. So we take fitness, we take finance, and we put it together for you. If you are a busy entrepreneur or somebody who's work, and you don't have time to take care of you, instead of looking for somebody to help you with your finances, instead of looking out for somebody to help you with your health and fitness, why not get both together in one? Because did you know having good fitness is going to help you out financially? Many studies have showed that, and being well off financially helps you out with your health and fitness. You're more likely to take care of yourself. So these are things that come together. So why shouldn't there be a company that does both together? We are going to teach you instead of tell you how to do things, which is probably the most important detail, especially on my end when it comes to fitness. Programming your workouts for you that fit your schedule with what you have so you can do it on your own. On top of that, we're going to track nutrition. I'm going to set goals for you so you have an understanding of how to get ahead in your own personal life. Keith is going to help you get out of debt if you're suffering on that end, show you how to invest, teach you the difference between a 401k and a Roth IRA, all these things that we do not know the answers to. Now you have the opportunity to work with both of us to get it out. So I highly recommend you guys check us out, fitbodiesfatwallets.com. Again, that is fitbodiesfatwallets.com. We are offering all of our podcast listeners 10% off of all services. Go check it out, guys. F Squared Consulting. Look forward to seeing you there. Now, kind of to take that and to go into what we're talking about with, we could keep all spinal, but I think low back pain is the most common thing. Let's bring it to the fitness realm, right? So I've talked to a bunch of chiropractors about that, and we really never talked about specific exercises to do and to not do with somebody who, let's just keep the example of a disc herniation. So that's going to be my question to you. What are some specific actions you think you should do and not do if I have a disc herniation in my lumbar?
I would just start off with a brief qualifier there's no spine exercise or universal exercise that's good for every sciatica or disc bulge patient. But then I would say it might be best to start off with what messes up the disc more. Maybe that would be a good place, and that will kind of inform what is safer for a disc. A disc is injured by excessive bending, twisting, and loading. So, flexing, extending, twisting it too much, putting weight on your back that your spine is not strong enough to take on. And so some common gym exercises that replicate these type of mechanisms are certain stretches, like hamstring stretches, where you're rounding your spine. In that case, not only are you flexing your disc and stretching the back fibers of the disc, you're also creating tension on the sciatic nerve. So things that stretch the hamstrings also stretch out and damage the sciatic nerve. So we see many patients who keep themselves in pain from a stretching program in that way. Another thing that hurts that we commonly see are things that repeatedly flex the spine. Sit-ups, curls, all of those variations, you're actually further propagating the injury mechanism in those cases. A disc that's injured, it's injured from too much bending, twisting, and loading. So it definitely doesn't want more bending and twisting. And so when you think about sit-ups, you think about knees to chest, these kind of things replicate that kind of bending mechanism. And sometimes the bending is accidental. It's that so-called butt wink at the bottom of a squat. So that's a bend that's occurring under tremendous loads. And that's probably the worst thing you could do for your disc injury. So what helps the disc, most disc injuries? They're usually things that involve stabilizing the lumbar spine and dorsal muscles. And these are, as a category, they have a lot in common and include planks. So planks, as you know, it's an isometric exercise. Your spine position doesn't change during the exercise. You're getting into a position and you're holding that position to resist some sort of challenge, right? So then one of the starting points for us standard spine patients that will work for mini disc patients is something we know we're described often as the McGill Big Three. That's the bird dog, the side plank, and an exercise called a modified curl. And all three of those exercises, they train different parts of the spine and the torso, because we often think about the spine as just the back, but really it's a 360 structure that's supporting it. It's like a barrel around the spine with the abdominal muscles at the front and the sides, and finally the back muscles, in the posterior aspect. And so you're really trying to develop a lot of the goals are learning to develop first quality movement patterns, which usually involve holding the spine stable. 2 is developing endurance in the spine, because endurance is what's going to keep you from fatiguing and losing your form during your everyday life and during exercises as well. And so I would say the big three, there's certain pulls, especially with TRX, like the TRX low row is often a good one. Push-ups, which is a push-up is a plank exercise with with an additional component to it. Certain types of front plank and front plank variations can be helpful. And then these are, of course, are more exercises for rehabilitating patients. It's not the end all be all if there's an athletic goal at the end. And as you see with different athletes, the proper training program will depend on the sport and the position and the person's unique characteristics as well.
And I'm going to break down in really stupid layman terms exactly what you said for everybody else. So,
please.
It was great, though. So if you took your spine, and for those that are audio, I'm going to just use my hand as a visual, and it's straight up and down, and I took a load, and I went straight down this way. This position, your spine can hold the most amount of load. This is where it's the strongest, right here. The second strongest, or the middle, is this way, pushing in from the side straight in to the spine. This is your flexion extension. It can take a decent amount of load this way. The absolute worst way to take a load in your spine, twisting, sitting anything in your transverse plane. So a good example of this would be Russian twist. As a lot of people throw a lot of weight on that one, and it makes me want to cringe really hard, especially when they do it fast, because you're throwing weight quickly from one side to the other while twisting your body. Your spine can't handle a lot of pressure like that, and that's when plops a slip a disc. It's exactly what the example I gave you. When someone bends over and twists to grab something and pulls it up through. So that's kind of what you're going into as far as good, bad, looking at it. Never heard the thing about the hamstring stretch before. Very interesting point. Makes sense when you explain it. And the other point you mentioned was butt winking, which is you're exactly right. A lot of people get that, especially when they're not being watched. They'll get the little spine will kind of curve out like this, and you're getting a lot of weight pushing in an awkward direction against your spine, especially if you're squatting heavy. Easy recommendation: change it to sit stands. Then still squat. If you want to keep your weight, keep your weight. But if you go straight down to a sitting position, it's going to prevent you from throwing your butt all the way out. So go a little alternate there. I have a specific exercise for you. If you don't know the name of the exercise, it's fine. I absolutely hate it. I actually have 4 banned workouts that my trainers are not allowed to teach in our gym. Yes, we have a banned workout list because people come up with the craziest stuff. One of them has gained a lot of popularity. So I'm never allowing it, but I want to hear you say, you know what a good morning is?
A good morning. Is that different from a Jefferson curl? Is that?
Yeah. A
It's
good morning is, you know what a stiff leg deadlift is?
yes.
Yeah. So it's that movement of a stiff leg deadlift, except you're loading a barbell exactly where you would put a back squat. So in a back squat, the barbell's here. So I'm loading this direction, and then I'm basically just bending over like a stiff leg deadlift.
Okay, I think I know. It's almost like it's like a hip hinge where you don't round your spine, but you're loading your back like it's a back squat.
Yeah.
That's the good morning. Oh yeah, so I think that it's certainly a high risk exercise. I'll give one that is, I think, even more banned, and maybe you could tell me if it's on your list or not.
All right.
Because a good morning, it subjects the spine to two big forces. One is there's that downward compression one that you're showing where your spine is, there's a weight pressing down. But then when you bend your spine over, then there's another type of force that happens that's called a shear force, like a slipping force. And so if you do that exercise and let's say you're able to keep perfect form, you might be able to tolerate it, but the rate of injury is going to be high because there's a good chance you're going to bend your spine. And the other point that's more important and why you're rightly concerned about it is shear force is even more dangerous than compression force on its own. So there's the NIOSH, the National Institute of Occupational Health and Safety. They put out numbers about, well, how much of this load can your back take before you're probably going to get injury, or that load. The load that you can take for shear is about a third of the amount you can take for compression. So you're trying to avoid this exercise that has compression and shear. But I would say even worse than that is the Jefferson curl. So that's an exercise where you're standing, often you're holding the weight to your side, but you're kind of leaning over and intentionally rounding your spine segment by segment. I mean, you can hardly design a better exercise to destroy the disc because you have the potent combination of the compression load, you have shear load, and you're rounding your spine, which destabilizes it and crushes down on the disc in the front, stretches the nerve, the annulus kind of collagen fibers in the back. So you can create injuries fairly quickly if you give a Jefferson curl to most people.
It is now going on our list.
Yeah, I would say that's even more evil than the good morning. The good morning, I think there's a select few. There's like a very genetically gifted athletic people who might pull it off. Jefferson curl, it's even worse.
Yeah, definitely not that. And we don't have this machine, so thank God. But I know that the bigger gyms, they have it. It's basically mimics a Russian twist, and they call it spinal rotation. So you're on your knees and you're upright and you're pressed up against the machine, and you use your hips to turn to the side. And you can load like 200 pounds. Yeah. You're just watching people, they're just this way, and they're turning their hips the other direction. I'm just like, oh my God, no, stop. My point being, without going into 600 different rants, there's a risk versus reward for every exercise. You have the potential of getting hurt doing absolutely anything. You can walk to your mailbox, which is probably one of the safest freaking things to do, and highly recommend it, and you can trip and fall. Like, there's risk reward to everything. Our point being, there's exercises that are not worth the risk and have alternatives that are way safer. Because the last thing you want, and trust me from experience, is to hurt your spine because it doesn't really heal. So just take that into consideration when you're doing certain things at the gym. And if you're questioning, ask a professional and not just anybody. Don't ask your friend you're working out with who's also 18 years old. Go talk to somebody who does this for a living and who understands it. Email me. Happy to answer you guys. I have very passionate about some exercises we don't allow. So definitely recommend. So we've gone through postural, we've gone through the fitness kind of do's and don'ts for you. Is there anything else that you think people should incorporate to help either get over a back injury or help prevent?
Yes, the first thing that comes to mind is if your back can take it, which is most of the time walking. Walking is the original spine exercise. We don't think about walking as a spine stabilizer, but it absolutely is. When you're walking, you're moving forward, there's forward momentum, but your spine isn't really wobbling or jackknifing forward because your muscles are very precisely just keeping the right level of tension and control. And then walking naturally has variety where you take step with one foot and another. There's this asymmetry to it, but it evens out because you're doing it equally. Learning what the right way to walk and how much you can walk, that there's a pretty big range for that. And then I would say also training sensibly is a big thing. I think a lot of people are often in the gym, they're kind of working out their demons is the sense I get. I mean, and then that's fine that's fine on a mental level. I think it's very helpful, but you actually will get into a darker place if you do it so well that you don't respect your body and you're overtraining yourself. And I find that there's a lot of people who they don't really know why they're training exactly. They know it makes them feel better, but then they're so aggressive about it in terms of the amount of exercise and load they want to take on. And they're just kind of desk jockeys like us. They're just sitting around most of the day. So really the sensible training, avoiding that injury. And I know you said earlier, it's quite hard to heal some of these injuries. I mean, even spine injuries, disc injuries, they can heal. Vast majority can heal with the right direction and therapy program, but you don't want to dig yourself out of that, put yourself in that hole if you don't have to.
Yeah, and just one more hard question, just because it's something that it's personal to me. Spinal surgery. Are there cases that we wouldn't recommend something like a lobectomy that I've seen gone horribly wrong, as opposed to finding different alternatives? Because I don't know if it's overly pushed because of the pay, because they could hit your insurance for a lot more, or if it's actually needed. But I mean, I'm also full disclosure on this. People don't come to me when spinal surgery goes great. They come to me when they screw up spinal surgery. So I do see it at higher rates than most people. So I can admit that. But I don't know. I kind of wanted to leave it up to you if you thought it was something that's feasible or kind of a last resort.
I think that there's truth in both things you said. Spine surgery is overprescribed. And I'm in your position too, where if your spine surgery went so great, you're not going to find a clinician like myself to see. But I would say that there are instances, and I could think of some even within the last, 2-3 months, where I've referred patients for surgery because it was the only safe choice they had. I'll give a classic example because many even clinicians miss this diagnosis. It's a dangerous compression of the spinal nerve roots. So think of it as it's almost like the worst sciatica you can imagine. You're not just the disc bulge and other problems are compressing not just one nerve, causing zapping pain down the leg. It's crushing so many nerves that it starts to affect the bladder. So some of these patients, they can become incontinent. They can get sexual dysfunction like erectile dysfunction of a very absolute kind. And they can get even loss of bowel function. And the kind of fascinating thing about some of these injuries is sometimes there's not even that much pain. Like sometimes the main symptom are some of these neurological deficits. And because it's not pain, it's not sciatica, some of these patients don't recognize that it's actually coming from the spine. So this specific syndrome I'm describing is called cauda equina syndrome. And I find that in those cases, most cauda equina syndromes need surgery. And so then there's different ways you can kind of figure out if you need surgery. I mean, you always want to be doing this under the guidance of your medical team, and it should always include a doctor. And it should usually include doctors who are not just surgeons, because that's true. If you're a therapist, many things look like therapy is going to fix it if you're a surgeon. And it really depends on the case who has the right answer. But I find that if you have a good team, including non-surgeon physicians and surgery physicians, if there's any disagreement, get a second or a third opinion about it. And I would actually advise your listeners, don't tell the other doctors what your diagnosis is. Don't tell them what the other doctor said, because I think some of us are very agreeable, so we'll just kind of not kind of agree just because it's kind of, there's like this kind of social element to it, which I don't think is so great, but that's kind of how medical systems work, especially if you're seeing a second opinion within the same practice. That's almost like getting the same doctor, because the first doctor can see the note of the original doctor. But then I would say go to a different health system. Don't disclose that, at least at first, what the other doctors say. And I often tell my patients that they'll say, oh, I saw this other doctor, I don't know, earlier today or last week. And I say, okay, don't tell me what they said. I'll tell you what I think. And then if it converges, you'll know I'm not just nodding my head in agreement. And so I would say most of the time, I would say most surgeries would say somewhere above 90, 95%. I would say, let's just say 90% of surgeries up to that many can be avoided depending on the indication. Because there's indications like the cauda equina syndrome where you should send, at least for surgical evaluation, you should send 100% of your patients virtually for at least the consultation. And then there might be some special reason they shouldn't get a surgery, but that's kind of how I would think about it. Get it down to the diagnosis of what's the problem, the nature of the problem. And even some kind of classic sciaticas, imagine I tell you sciatica, no posture changes the pain. It's severe pain all the time. The leg is melting away, the calf is gone, the person's glute is melted away because of the lack of nerve signal to it. And it's progressively getting worse. So these are situations where it's not as clear cut as cauda equina, but they may very probably need a surgery as well.
Yeah, I love that answer. It was very, very informative. So Sandra, I'm gonna ask the final two questions I ask everybody on this show just to wrap it up. The first one is, if you were to summarize this episode in one or two sentences, what would be your take-home message?
My take-home message is injury is caused by the wrong kind of accumulation of postural movements and loads and exercises, and it can often be healed by the correct combination of postures, motions, loads, and exercises.
I like that. And then the second question, how can people find you, get a hold of you? I know you wrote a book, so please go ahead and give us all the information for that.
Oh, yes. The book can be found on Amazon. The title is Specific Spine, A Doctor's Guide to a Healthy Back. And it can also be found on my clinical website, masterymedical.com.
Love it. Sandra, thank you for coming on. And thank you guys for listening to this week's episode of Health and Fitness Redefined. Don't forget, hit that subscribe button and join us next week as we dive deeper into this ever-changing field. And remember, fitness is medicine. Until next time.